speaker is going to be Dr. Andrew McGarry. He's a member of our HDSA board and also, again, a movement disorder specialist at Cooper. And so, Dr. McGarry, are you there?
I am. Hi, Corlin.
Hello. All right. Are you able to share your screen with us?
I will try.
Okay. If you can't, let me know, because I think I have yours around here somewhere. So.
All right. How did that go?
I think that's good.
Let's see. So you can see the first slide still in the PowerPoint format. So if I go to slideshow. All right. How's that?
That works.
Okay. Let's see. Let me just get my bearings. All right. Well, good morning, everyone. Thank you for your time. Whoop. Oh, so I don't have my bearings. I'm sliding through these already. Here we go. What we were aiming to talk about today, after that really excellent talk from Amy, that was excellent practical clinical advice, was something scientifically that I don't think necessarily gets a lot of attention. And from a research standpoint, is becoming of more interest to us. So we thought we'd share it with you and see what you thought. And it pertains to the cerebellum, which is a very important part of the brain that isn't always thought of as part of Huntington's disease. So first off, what is the cerebellum? I have a picture here, just a simple schematic of the brain that is familiar to most people from, in passing on TV when you see an MRI, or if you've had imaging done, you might have been shown something like this. And the majority of the brain is this big sort of wrinkly structure that has a tube, if you'd like, kind of hanging out of the bottom. And nestled between that sort of tube-like structure and the big wrinkly part on top in the back that you see colored in false color there in orange, that's the cerebellum. And it's really quite important. It has nearly 80% of your neurons, give or take, depending on where you're reading. And so that often surprises people, because when you think about the brain, we tend to think of the cortex, which is the outer lining, certainly very important, certainly many neurons, but not even close compared to how many neurons are in the cerebellum. And that has something to do with its design, which is quite intricate. So the cerebellum's function is very intricate, and therefore there's a lot of sort of neuronal horsepower, if you'd like, required, a lot of neuronal person power, if you'd like. And so its main job, although it has some really surprising roles too, is to help with coordination and smooth voluntary movement. So if you think about moving through your day and all the things that you have to get done in an accurate and coordinated fashion, tying your shoes, pouring milk into your cereal, putting a harness on your dog before you go for a walk, it's very easy to take for granted that that information has to come from somewhere, and it also has to be compared while it's happening, while that command is being executed, to what is actually happening. So there's what you intend to do. I'm going to slip this harness over Riley's head so we can go for a walk. And I know his left paw, I got to pick up to do that. I intend to do that. But then somewhere in my brain, in my nervous system, there has to be real-time decision-making about whether that is in fact happening. And your cerebellum has a lot to do with that, because it gets all sorts of interesting information about what you're seeing and what you're feeling, literally in your hands, the weight of the harness, the weight of your dog's paw, the position of your limbs, where your trunk is in space. Are you balanced when you're leaning down to do this? As you think about it, there's a lot that goes into executing voluntary movement that you intend. And so the cerebellum, because of these large tasks, really, as you think about it, is quite complicated in the sense that there's a lot of neurons in there. It's very heavily connected to the entire nervous system. So it gets information coming down from the cortex, which is where strategies and motor patterns are being sent to it, the things you intend to do. That's the I intend to walk my dog part. How do I do that? Well, I got to put the harness on. How do you put the harness on? That kind of thing. And it also gets information coming from the outside. So if we think about the spinal cord and the brainstem towards the bottom of that picture, that sort of tube-looking thing hanging out of the bottom, that's actually a giant highway that's also sending information upward. And so where you are in space, where your limbs are, where your hands are, what you can feel in your hands, all of that information is going to the cerebellum, who's then crunching it to be sure that in real time, what you're intending to do is actually what's happening. So as you think about it, it's really an amazing part of the brain. And so because it is fairly complicated, we have to make it uncomplicated. And this is not meant to make it complicated. So please bear with me. We won't spend a ton of time on this slide. But the idea here is that the cerebellum also has layers like the rest of the brain does. And so the top of this picture is the outside of the cerebellum. And the bottom of this picture is as you go progressively downward toward the middle. And what this is a cross section. So if you had a birthday cake and cut a slice out, you know how you can see the different layers? There's the cake, and then there's the chocolate, and then there's another layer of cake, and then maybe there's some strawberry or whatever. This is meant to look like that. So these are the different layers of the cake, if you'd like. And there are three main ones. There's the molecular layer that's on the outside. There's the Purkinje layer, which is really important. We're going to spend a second on that one. And then there's the granular layer. So the punchline here is that information comes up. It goes in from the bottom of the slide, and it has to eventually get to the top where you see those parallel fibers coming from the granule cells down in the granular layer. And it has to be thought about and organized, and then eventually sent back down through the Purkinje cells. So the Purkinje cell, that sort of brown colored neuron that you see there with the, the sort of wavy seaweed looking tendrils in the molecular layer, that Purkinje cell is listening to all of the other inputs from these neurons going up and these connections there and making decisions about what to do. Then when it decides that, it sends information down. So that blue line going up, where you see mossy fiber, that's a highway going up, information coming in. And the Purkinje layer, that brown colored neuron you see, is sending information going down. That's going out, back out to the body. So this is consistent with what we know the cerebellum is supposed to do. It's supposed to get information going in, it's got to crunch it, and then it's got to make a decision and send information back out about whether you should be moving differently or doing things differently. So this is more of the same. We won't belabor this too badly, but I liked the image on the left because it's that sort of three-dimensional view that makes it a little easier to see. You can see that there's three layers again: the outer molecular layer, the Purkinje cell layer, and then the granule cell layer is the deepest one down. There's information coming in. I apologize for the small text, but those climbing fibers and the mossy fibers, that's information coming in. And again, you see the Purkinje cell over on the left-hand picture with many, many what we call arborizations, these sort of dendrites that are very spread out to go ahead and connect with all the other neurons around it. And so the beauty of this design by Mama Nature is that she has these things arranged in a grid. So if you look at the right side now, you can see that the Purkinje cells, their axons, if you'd like, are wrapped up in these parallel fibers that are coming from the granular cells in green behind them. So these connections, if they look like an orthogonal grid, like a 90-degree setup, that's because they largely are. And Mama Nature then has a ability to represent three-dimensional space according to where things are in the periphery in your cerebellum. So the cerebellum is what we call somatotopically organized. So there's a part of your cerebellum that corresponds to your right hand. There's another part that corresponds to your left hand. There's a part that corresponds to your right leg, and so on, because of this organization. And so why that's so interesting is because, and why it's so important is because it's very, 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 very integrated. So in a very short period of time, information about what your right foot is doing can be integrated with what your right hand is doing. Information about what your right hand is doing can be integrated with what your left hand is doing. And so if you're a guitarist, your right hand and your left hand, they need to know what each other is doing. And that's happening in real time in your cerebellum. Amazing. And so this is a really cool part of the brain. As the task implies, there's many, many, many neurons. As the slide implies, there's a million different types of neurons. Please don't get bogged down. I'm sorry for that. But you can see that there's a lot of different color neurons in there. They all have some different jobs to sort of create this message that has to go out. But the punchline, and then we'll leave this slide, and thank you for listening, is that the Purkinje cell on the right-hand side has to eventually tell the deep cerebellar nuclei what the story is. Here's what you're going to do. And that's really important because the deep cerebellar nuclei, that's the only real output from the cerebellum. So the punchline after all that number crunching is that the Purkinje cell tells the deep cerebellar nuclei what to do, and then those deep nuclei send information to the rest of the body. So why am I telling you all this? Well, it's interesting by itself, I hope, but in Huntington's disease, which we're talking about today, this has not really been thought about a ton. So think about that for a second. The part of the brain that has 80% of the neurons in it has not really been thought about at length in Huntington's disease. Well, why would that be? Well, when Huntington's was described as far as changes in brain structure, it was noticed that the striatum, which is the part that everyone thinks about, was clearly changing. And so that's your caudate nucleus and your putamen. You can see that on imaging. You can see that on neuropath. When you look at brain slices under a microscope, you can see that the neurons are changing. Over time, apart from the striatum, changes in the cortex also became more widely appreciated as we got more sophisticated in thinking about the connections, looking in other parts of the brain, following it through time and seeing change. That also has become very widely appreciated as changing. In fact, the white matter in the brain, which is situated below the cortex and what makes up the big bulk of the cortical hemispheres, that's also known to change with some fancier imaging techniques in the last couple of decades. So why is the cerebellum less appreciated? And why would this really important part of the brain not really get the same attention? Well, it's not as obvious, to be honest. It's not as obvious clinically, and I think it's been a little bit tricky to find neuropathologically, which we'll talk about in a second. So if we think about how we usually think of Huntington's, we know there's chorea, we know there's cognitive change and behavioral change. Those are the three big arms from a treatment standpoint that we go after. There are other movements than chorea. There's dystonia, where limbs can get stiff and sort of stuck as you're moving. There's Parkinsonism, so over time the chorea tends to lessen and stiffness and slowness tend to pick up a bit. You're not overtly ataxic like in other cerebellar diseases. So if you look at diseases where it's only the cerebellum that's influenced, you can see that there's usually a way people look and move that's incoordinated or imbalanced. If you've ever had a glass or two too many of wine or champagne on New Year's Eve, you know what it feels like to have your cerebellum not quite serving you. And so that sort of jangly, unsteady, that incoordinated, unstable gait is often what is seen in other cerebellar diseases. And we know in Huntington's, chorea can be problematic, slowness called bradykinesia can be problematic, dystonia can be problematic. And so those things are reflected in our gold standard clinicometric measuring scale. And that's the Unified Huntington's Disease Rating Scale. If you look at the total motor score, you measure chorea, you measure slowness, you measure dystonia, but there's no overt way to say whether someone's ataxic. So even in looking at how we measure things, there's a legacy effect seen in how we measure things where we don't even really think about formal cerebellar function, which is really quite interesting. So why do we want to think about this? Well, if you look at people carefully enough, you can see that voluntary movement is impaired, and not necessarily from chorea or dystonia. So there's been this sort of anecdotal sense clinically that people can be ataxic, but it's just not gotten as much attention, in part because a lot of the involuntary stuff captures attention. But of course, voluntary movement is critical. And so whether there's anything that influences voluntary movement is really just as important. Although again, we tend to focus on the involuntary things and how that influences what we do. We know that gait and balance changes. We know that there's fall risk, and we know that speech changes. So all of those things are heavily related to cerebellar function. Think again back to if you've had a couple glasses of wine too many on New Year's Eve. You know your gait has changed. You know you might fall. You know your speech has changed. So again, illustrating this idea that these things can be more subtly present in Huntington's disease. And so we should probably think whether there's opportunities to explore treatment for cerebellar function if it's abnormal. And so let's go to the literature for a little bit. Couple things. What's in the scientific literature that tells us this is worthwhile? Well, there's a paper from Movement Disorders in 2014 where the authors looked at changes on MRI and wondered what that correlated to clinically. So they looked at 22 folks with Huntington's disease and 12 folks without, and they noticed that the cerebellar volume for people with Huntington's disease was impaired with gait and behavioral symptoms. They also used some fancy techniques to see how tightly packed the white matter was. And they noticed that there was less tightly packed white matter in people with Huntington's disease in a way that correlated with their total motor score. So in other words, as their total motor score was changing, the white matter was becoming a little bit less tightly packed because it was wearing down and degenerating. And they also noticed that eye movements, which are in part cerebellar, tandem gait, which is when you put one foot in front of the other, like you're walking on a tightrope. That's also cerebellar. That's a part of the cerebellum called the vermis that subtends that. And timed finger tapping, which is actually a speed and coordination task that the cerebellum has a lot to do with, also suffered in a way that correlated with these diffusion abnormalities. So you're getting indirect imaging evidence that the cerebellum and some of its outflow is impaired in Huntington's disease. You can also look at whether or not the nearby structures have changed. So the cerebellum is so complicated that it has friends nearby in a part of the brain called the brainstem. So if we look at this picture, we can see the cerebellum is on the right cerebellar hemisphere image. And some of the structures next to it, the peduncle, the pons, the medulla, there are nuclei that live in there, mesencephalon, quadrigeminal plate. There are places in there that have important connections with the cerebellum, and they also change. So in this brain pathology paper from 2014, they looked at that part of the brain to see whether there were changes, and there were. The pontine nuclei, a place called the inferior olivary nucleus, some of the medial, lateral, and superior vestibular nuclei. Those are the gyroscopes in your head. That's the part of your brain that tells you where you are in space when you turn your head. And so that information is really critical because your brain needs to know when you're moving, and if so, how fast and in what direction. And so if that isn't working because it's not communicating with the cerebellum properly, or they're not speaking the same language to one another, you can end up feeling unsteady. So we have evidence on pathology that the surrounding cerebellar structures, its sort of allies or friends, are also having trouble. So more recently, a group looked at whether cerebellar degeneration correlated with motor symptoms. And they were also interested in seeing whether or not that always held up compared to other types of symptoms people had in Huntington's disease. And they noticed that in separating people into two main groups, one that seemed to have more behavioral trouble and one that seemed to have more motor trouble, 43% loss of Purkinje cell layer was noticed in people with more motor dysfunction. So let's call a quick timeout and go back to that early slide where we remember that the Purkinje cell layer is the main output to these deep cerebellar nuclei. The Purkinje cell is the main decision maker, makes important judgments about what your movement should look like. And now they're going away as Huntington's advances. This is really important because it represents perhaps a part of the cerebellum that is especially vulnerable, one could wonder about. Interestingly, this loss didn't correlate to what your striatum looked like, because remember, that's the more famous part of the brain that changes in Huntington's, your CAG repeat length, or your age. So it's not immediately clear whether there's a dose effect, if you'd like, from these other things, like how long the CAG repeat is or how old you are. There's more to learn here. So this is a panel from that paper where they looked at people without Huntington's disease. The squiggly stuff you see, those are brain sections that are stained with things to allow you to see neurons and layers of the brain more easily. On the left side where it says control, that column going down, those are people without Huntington's disease. The middle column where it says HD mood, those are people who predominantly had mood trouble. And all the way to the right where it says HD motor, those are people who predominantly had movement trouble. And I want to draw your attention to the third row, those panels labeled G, H, and I. And so if you look at those sort of dark brown spots, those are cells. Those are neurons. Those are Purkinje cells, actually. And so you see there's a whole row of them in panel G. Then you go over to panel H, which is people with Huntington's and mood trouble. There's fewer of them. And then you move over one more, and you can see that in the motor section, there's even fewer. So this is an illustration of what they saw. People with motor dysfunction seem to have fewer of these Purkinje cells. And so when scientists look at the brain, they will stain the brain to show these things more easily. And they will actually sit there and count neurons, which I have done. It takes time, but it's really valuable because it allows you to see what it is that's actually happening. And so we'll look at one last paper here quickly. This is a clinical paper. So we talked about imaging, we talked about neuropathology, but what about clinic? In the end, that's what matters, right? What it is that people are showing you. What's the clinical translation? Because that's what you'd really want to be able to influence so that people felt better in developing a therapy. And so this group, which I really congratulate them for looking at this, and this is fairly recent, 2020, they looked at 72 patients who got examination with ataxia rating scales, or something called the International Cooperative Ataxia Rating Scale, the ICARS. And they noticed that at the time of the examination, all comers, so wherever you were in your disease trajectory, 71% of them formally met criteria on this ataxia rating scale. In fact, 8% of them had it as the first symptom and looking at what their historical trajectory was like, that surprised me, that it could be quite that high. And what's important here too is that in general, despite that 8% as the first symptom, it's typically associated with longer duration of disease and severity of illness. So here's a graphic depiction of that. There are 5 color lines on this slide. They correspond to different features of Huntington's. So you'll see at the very bottom, blue is chorea, orange is ataxia, purple is dystonia, yellow is behavioral, and green is cognitive. On the right side, the y-axis, you see that there's a percentage of participants who had these issues, and it goes from 50% to 100%. And you notice that on the x-axis, going across the slide from right to left, you can see that there's time points by year, and they're grouped 0 to 5, 6 to 10, 11 to 15, and greater than 15. I want to draw your attention to the chorea curve, which is blue. You can see that through time, as people accumulate years with disease, the amount of chorea goes down. You see that blue line going down. If you look at the ataxia curve, you can see that it's relatively less common from 0 to 5 years compared to, say, chorea or dystonia, which is the purple line. But as you go 6 to 10 years, 11 to 15 years, you can see that the ataxia line is going up as the chorea line is going down, and as the dystonia line is also going up. And as we know, behavioral and cognitive change also tends to advance with time. So this is, I think, surprising to many people who think about chorea because it's early, and it's easy to see. Dystonia, a little harder to see, but also becomes more obvious. It's usually pointed out by a clinician. But look at ataxia, increasing steadily through time. So why I'm telling you this is probably an under-recognized problem that accumulates importance with time in the trajectory of Huntington's disease. So that just strengthens the idea that we need to start paying attention to this more. So last slide. Thank you for listening. What now? What would you say are the next steps? Well, an easy low-hanging fruit thing would be to wonder if medications that could influence cerebellar function are in fact helpful for ataxia and Huntington's disease. And so there's a number of medicines that are sometimes tried for ataxia, but I have to say there's not a lot. You know, if you see people with other cerebellar diseases and you look at the literature around them, they're relatively rare compared to, say, Parkinson's disease. And it's difficult to get anything to sort of make the cerebellum behave well because it is so complicated. And so the therapeutic index, if you'd like, the ability to elicit improvement and not make people feel bad, creating side effects, for a lot of these drugs in cerebellar diseases is pretty narrow. And so they're not easy to use because you might need to try high doses that people don't tolerate. They don't necessarily work. And so there's probably limited ceiling to trying this, but I put it here because there's not a whole lot of this at all in Huntington's disease. There have not been a lot of medications that could influence cerebellar function actually tried in well-designed clinical trials. So this is probably the first thing to think about. The next thing to think about, and in part, this is a little bit of hype because there's a fair amount of hype around this. The antisense oligonucleotides or the gene therapy studies, but particularly the ASO studies, you could wonder whether they would change cerebellar function. The reason why that's worth thinking about is because when people, for the moment, get their ASOs injected by lumbar puncture, they have to swim up towards the brain. And the cerebellum, remember, is situated in that kind of cool spot between the spinal cord and the brainstem and the big bulky part of the brain, the cerebrum. And there are spaces there where CSF, cerebrospinal fluid, bathes very closely to some of these very important structures in the cerebellum, you know, the fourth ventricle in particular. So you wonder whether there's an easy access point for the ASOs to get in there and maybe influence the cerebellum. That'll be very interesting. So I'm mentioning that really out of sort of scientific interest, since people are thinking about ASOs for, you know, the famous stuff. Does it change the striatum? Does it change the cortex? Well, I'm quite interested whether it does anything to the cerebellum too. So I wanted to be sure we were all thinking about that. The third thing would be alternative therapies. And this is something we're personally interested in at Cooper. You know, Amy, myself, Dr. Basant Pradhan, who's a psychiatrist with a background in neurology, we're thinking over whether stimulating the cerebellum would be a good idea. And so the Purkinje cells, remember, they're the main output. We talked about that. And they have a very modifying influence on the deep nuclei in the cerebellum. They sort of cool it off from its normal excitatory role for the rest of the cortex. And so there's this loop. And so we're wondering whether if the Purkinje cells are going away, maybe that's not a target, but if the deep cerebellar nuclei are there, maybe we stimulate them. Maybe we sort of mimic what Purkinje cells normally do with a magnetic field. That's the idea. So we're in the process of drawing that up. And in the sense that that's a clinical trial, you might be interested, and we'd be interested in talking to you more. That sounds like it might be cool. We'll let you know more as we sort of get this crystallized. We may be advertising if people are interested in volunteering. in being in the study. So please stay tuned. This would not be a medication. It would not be pharmacologic in the sense that medicines are chemicals that bind to receptors and elicit changes in cells. This would be a magnetic field that could be turned on or off. And so what we'd have to learn is whether or not any effect persisted. And we'd have to also learn, if it worked, how often do you need it? So to be determined. Keep your eyes peeled and your ears tuned. And so finally, that really just underscores we don't have much for this. We need novel approaches to cerebellar function. And I think with time, and more sophisticated pharmacological approaches, and hopefully something even with magnetic stimulation, I think we're going to be a little bit better able to modify this clinically, and hopefully then a lot better able eventually. So I'll stop there. I know that's a lot on a Saturday morning. Hope to not bore you with the science, but I think a lot of people like it, and I think this is really exciting. So thank you for your time. Happy to take any questions.
Thank you, Dr. McGarry. I actually do have one question that came through the chat for you, and maybe potentially for everybody. Has there been any slowing down of HD research due to COVID? Has it affected any studies?
That's a good question. I think as a general matter, COVID clearly influenced what people are able to do early on in particular. A lot of what we do is clinically driven. So outcome measures that have to be obtained in person, imaging studies that have to be obtained surrounded by other people, who operate the imaging devices or who also contemporaneously, administer other scales, clinical outcomes. So I'd say as a general matter, everything suffered, especially early on. I do think what we've noticed is that sites and particularly participants are very resilient and quite adaptive. And in a really short period of time, protocols for clinical studies were modified quite impressively to allow for outcome measures to be done remotely. And so that could either be through a video screen or a telephone. And in other instances, trying to minimize exposure to other people. So I have to think, I don't think any major Huntington studies managed to escape this effect early, but I'm fairly confident that, like most other studies, they figured out how to keep going.
Okay. I think, Stacy, did you have something to add to that? I know.
Yeah, thank you, actually, Dr. McGarry. That was a great presentation. I keep calling you Dr. McGarry. You're always going to be Dr. McGarry to me. That was such a good presentation. I'm a science nerd.
Yeah, well, Dr. Stacy, you're a scientist.
But the loss of the Purkinje cells, that 43% loss in people with HD patients, I think is fascinating, because one of the things we're always trying to figure out is the differences, and the fact that it didn't correlate to the CAG levels or the age of onset in people, to me, is fascinating. I mean, could that be something that is partial? I know you don't like to say for sure, but could that be one of the contributing factors to the differences in age of onset with people with the disease? Because there's a huge variation. When you look at all those studies with the age of onset, there's a huge variation. And I know it's linked to a lot of different things, but you think this could possibly be one of those factors too, that they haven't really explored?
It's a good question. In that small set in the study, they didn't notice that there was a relationship between age of onset or Purkinje cell loss. And that's a really good question, because to some degree, you're wondering, okay, with time, we expect neurons to be lost. And so if you've had it longer, meaning generally it showed up earlier, so therefore you've had it longer, does that mean you've had more time to lose these? Does that say something about a gradual process? Or do they get lost selectively in some other way? In other words, could you have Huntington's for a year and a half and really lose a lot of Purkinje neurons because they're selectively vulnerable. I don't think anybody knows that. That's a really interesting idea. Is there something in some people that would make the cerebellum especially vulnerable and maybe have more of a motor phenotype early versus later on? Because we do know that some people have very little chorea, and I don't mean adjusted for duration of disease, where we know that generally speaking it lessens. There are people that for one reason or another just don't have a lot of it. And then there are people who have a ton of it. And we don't even really still know why that is. On a molecular basis, what is it that's changing in some people more than others? So very similarly, you could wonder, is there anything to separate people who are more ataxic than not? And how would you predict that? And that's part of your question, which is a really good one. Is it age? Is it CAG? Is there something else that would help you predict? And we don't really have a good way of doing that, in part because there's not a ton of research just yet. You can see it kind of trickling out in our presentation today. A couple papers from 2014, one from 2020, 2019. So, a really ripe area to explore, I think, would be what it is that goes on in animal models in the cerebellum, because rats and mice, they have Purkinje cells. And you could look and see what it is that's changing, how to modify them. You could imagine a lot of good basic science that could be done to try to improve Purkinje cell function. So great question. And like many things, we don't know.
I know, unfortunately, I know. Because I know with Korea, my mom didn't have it and I don't have any. So it's a good thing. Well, you also talked about some of the medications that may influence the cerebellum. Are they already being used? Like Cloenza, I can't say this. Why can't I say this? Clonazepam. Thank you. Like those types of medications, are they approved already for other uses?
They are. Clonazepam is kind of a Swiss Army knife medication. It can be used in Huntington's for anxiety or trouble sleeping. So there are very likely some people who do take it. It's not been studied, to my knowledge, for things other than that. So in other words, it's not been studied with the express purpose of seeing if people have changes in their coordination or their gait. It's not been looked at as a treatment for ataxia. But
they approved medications.
So clonazepam is an FDA-approved medication. It's been around for a long time, right? And bupropion is also an antidepressant. That's been around for a while too. And that could be used in any generic sense to treat depression and Huntington's like anyone else. But it's not, to my knowledge, been studied expressly for ataxia in Huntington's.
Okay. Very cool. It's so interesting. There's so many good things going on. The magnetic stimulation study too. I think if you guys do that, I'm sure we can find plenty of volunteers.
That's great. We're still in the lab, if you'd like, figuring out how to best design that study, which I think is a lot of fun and really exciting, because the odds that it would be problematic the way medication sometimes can be, I think, would be low. And I also think that the temporary nature of the stimulation would also limit the potential side effects that someone would have. Of course, that's potentially a downside. If it's helpful, if the effect goes away, the next thing to figure out is, well, how do you get that to be sustained? And that's the next problem to have is, and a nice problem to have would be, well, is this something people would do every day? Would they put it on, for a couple hours a day to supplement, whatever medications they might be taking? Would it be used intermittently, maybe twice a day, once in the morning or once in the evening? We have no idea, because we don't even know what it does yet. So first things first, we want to establish whether in the clinic there's a visible effect, and then thereafter, the best use, if you'd like, the proper dosage, if you'd like, would have to be figured out in a much larger study. So this is still on the drawing board. We sort of showed you the drawing board.
It was a very drawing board. Thank you.
Sure.
One more question, Dr. McGarry, and I don't know if you know the, I think I know the answer. Somebody asked if brain donation is still happening. I know that Kayla and I have been working on updating, mostly Kayla, updating our resource guide, and we did call recently, and they did not say anything about not accepting brain donations, but I don't know if you've heard anything.
I confess I don't know. I don't know if Amy might, but I'm not aware. You know, we could see locally, when I think of neuropath, I think of Virginia Lee and John Trojanowski at Penn. I don't know how many Huntington's donations they take. We do a lot of Parkinson's and Alzheimer's, but
I know we do usually give out the information for Harvard, and then I believe Massachusetts General.
Yeah, Harvard Brain Bank is the big one, right? And I don't know, although I can ask them.
Okay, all right. And then Dr. Coulter, there was a question for you. Do you see any
Oops, sorry, Corlin, I think your feed might have paused.
I think it did. Yeah, sorry about that. So there was a question about for Dr. Coulter if she saw any reason to not get the vaccine. And I think I know the answer to that, but I don't want to speak for anybody. I don't know if she's still there. All right, well.
Her feed might be a little bit off, but it can be a little wonky, but I'd say as a general matter, no, you know, there's no reason to not get it. And it's sort of an individual decision based on your comfort with the science. You know, I've had people say, hey, this sounds neat, but, you know, they got it done inside a year. Does that make it fishy? You know, did they cut corners? And I just want to remind people when they ask that good question, you know, the outcome measure for those studies was what happened in your blood, which was very easy to measure. And a very important outcome that also happened, other than, hey, did you make antibodies, was while you were in the study, did you get sick? And it's remarkable, when people did get sick, which was clearly more rare in the treatment group, meaning the people who, you know, were given active vaccination. The most important part, I think, is that no one got really sick. That's the key. You know, when you think about how deadly the virus can be and how hard it is to know in whom that necessarily will be, although the risk factors that Amy mentioned are certainly important, it's really something you don't want to get at all if you can help it. And to see that people really didn't get very ill when they were treated, I thought was very encouraging. I also think the technology is pretty remarkable. You know, it's everything you need to make antibodies and nothing more. It's just a blueprint. You go ahead and read the blueprint, you manufacture the protein, it's seen as immunogenic, you make ammunition against it, you're good to go. It's really quite remarkable. So, you know, I can't think of a reason, considering all of the heavy duty things Amy mentioned about what being sick is like, that you should not go ahead and protect yourself against those things. In other words, I think people should get it.
Okay. All right. Thank you. All right. Well, thank you, Dr. McGarry. Really appreciate your time today.